This is the second workshop in our two-part series with Population Health Research Network Australia. Earlier in June, we hosted a similar workshop with Australian participants, and we're really looking forward to today's session to learn about any sort of similarities and differences that we see in community attitudes on using health data. So the objectives of this session are to compare engagement methods and experiences. We're going to discuss our findings and based on local context and interpret these based on local context. We're going to highlight some emerging issues in social license as well as some lessons learned. And really, we're hoping to facilitate some cross-cultural exchange. Very briefly, who we are: both Health Data Research Network Canada, or HDRN Canada, and the Population Health Research Network Australia, or PHRN Australia, are collaborative network organizations dedicated to advancing multi-regional health research and also to improving patient outcomes, advancing healthcare research, and informing policy decisions. So we'll start by providing some very brief background on community attitudes to health data use. We like to start off with this graphic just to demonstrate how it is becoming increasingly understood that data, and particularly health data in this context, they're powerful. So here are just some of the many academic and media highlights about data. You'll see many here are about the COVID-19 pandemic and this recognition that better data are needed to be collected to solve public health problems. With the acknowledgement of better data, though, there are many considerations that arise, right? So we think of privacy concerns, and we can see that reflected there, people accessing their own health data. But overall, I think the main takeaway is that the importance of data is being increasingly understood, and that's especially in today's era of machine learning, big data, artificial intelligence, et cetera. So it's also important to acknowledge what we already know about how the public feel about health data use. We know from existing work on this topic that members of the public see health data as an asset that should be used for public benefit, but their support is conditional. So what we mean by that is most people feel that certain conditions and risks must be addressed before they consider uses of health data to be acceptable. As an example, privacy considerations, so things like de-identifying data. Commercial motives, for example, a lot of people feel that commercial organizations should not be allowed to sell data. And of course, there are many considerations around equity and fairness, so particularly around data use that is about systematically marginalized populations, so in really ensuring that data does not result in discrimination or stigma against certain groups. I think we have just popped some existing reports and studies on this topic in the chat, so there's an excellent systematic review that has a lot of existing work on community attitudes about health data by Aitken and et al. And there's also a really good consensus statement by the same group. So what is health data social license? Before we get into the details of the projects and what we heard, it's important to understand this term. These terms are both directly linked with community attitudes on the use of health data. So interestingly, the mining industry is where the term social license was initially and more widely used. So you think about a mining company going into a community, they start to mine. The question is, do they have the support of the public? So what we like to say is that in order to act responsibly, an additional moral duty exists. And that's beyond compliance with laws and regulations. So it is possible for an activity to be legally allowed, but outside of social license. Increasingly, the term is being used to describe which data-related activities have the support of the public and under what conditions. So when we say that a use or a user of health data is within social license, we mean that it's a use or a user that at a minimum is publicly acceptable, but ideally has active public support. And again, we'll pop some resources in the chat on social license and health data social license that may be of interest to some of you. So now that we've provided some background and additional context into the existing research on community attitudes to health data and health data social license, we'll talk a little bit about the methods that each of us, so HDRN Canada and PHRN Australia, respectively took to engage with the public to learn about their perspectives on health data use. So I'll talk about what we did here in Canada. So we wanted to expand on the current research on community attitudes about health data by adding experienced public and patient advisors' views on two main things. One being essential requirements for health data social license. So an example of an essential requirement could be something like health data are not sold, or plain language is used by entities who are collecting health data, or accountable governance bodies in place. And we kind of categorized these requirements into 7 different categories. And we're going to be presenting the findings based on these 7 different requirement categories later on. And the second thing we wanted to explore was whether there were consensus on examples of health data uses and users that people felt were within and not within social license, as well as could be within social license with safeguards in place. Why did we choose this approach? So a lot of the previous research in this area asked people to provide their perspectives on health data uses and users, ones that they felt were acceptable or unacceptable. What we decided to do was to see if there were select uses and users that everyone in the group who we engaged with agreed upon. So uses and users that they all supported or all supposed. So in that case, we were trying to come to consensus on these essential requirements and examples of uses that they felt were within, not within, or could be within social license. So here's some select participant characteristics of the core group who we engaged with, 20 individuals. A relatively diverse group, as you'll see, particularly in terms of ethnocultural background, but of course with limitations, as we often see with this type of qualitative research. It's a small group, primarily older and well-educated. The group were half French and half English, so everything was conducted bilingually. We've used the term participants throughout, and I'll continue to do so. That's just for simplicity, but they were not participants in the traditional sense of the word, if you would use it as a research project, for example, but they were patient and public advisors who were engaged with the research team, and they were really the drivers of the content that was created. They weren't study participants. There was an additional group of 13 patient and public peer reviewers who reviewed the report that was created. Very similar characteristics in terms of relatively diverse ethnocultural background, but some limitations in terms of primarily older and well-educated as well. So at a high level, our methods really focused on inclusive public engagement. As a first step, the individuals we engaged with provided individual written submissions where we asked them to identify requirements for health data uses and users. And we gave them a list of based on previous studies, but they were not constrained to this list of essential requirements. And we also asked them to identify uses and users that they felt were within, not within, or could be within social license, as I just mentioned. These individual written submissions were followed by 2 facilitated group dialogue sessions in English and 2 in French to focus on both of these components. The results and the perspectives that were shared were then converted into a public report that was reviewed by these experienced patient and public advisors. So both the participants who were involved in the process and the other group of advisors who I mentioned, those were the peer reviewers. This was done in English and French, shared with the Public Health Agency of Canada, who had funded this work, and then more widely. We then asked participants and peer reviewers to evaluate the process using the Patient and Public Engagement Evaluation Tool, or the PPEET. This is the product of a Canadian collaboration of researchers and public and patient engagement practitioners out of McMaster University. Maybe some of you have heard of them. We'll be focused on the main findings here today and not the results of the evaluation, but please feel free to reach out if you'd like to know more about the results of the evaluation. And in a subsequent manuscript that we published, there are results and more details on the evaluation approach that we took, if you're interested in that. So a little bit more about how we captured perspectives. 2 main things I'm going to focus on. The first is inclusive design. And we took an inclusive design approach so that we could identify diversity of views. And particularly, we wanted to identify minority views that weren't necessarily captured in prior work in this area. The second thing I'm going to highlight is the use of a method called the 5-finger facilitation method. And this approach was used to help participants come to consensus, specifically on examples of health data uses and users that they felt were within or not within social license. So now I'll give a bit more detail on both of these approaches and this principle. So why inclusive design? We know that people who hold minority views are the ones who are least likely to be well served by the status quo, but they're also the holders of knowledge that are essential to design processes, policies, with products that work for everyone. So the entire population, not just the majority of the population. So the findings in the report that we developed include views and requirements that were supported by many participants, but also views and requirements for health data social license that were supported by only 1 or 2 participants. I think it's also important to acknowledge that, you know, the views of 1 or 2 people in our process still could represent thousands or more people across the country. I always want to acknowledge as well that our inclusive design approach was informed by the work of Yuta Trebrianis at the Inclusive Design Research Institute at OCAD University. And I really like that image on the slide there, just to show the importance of using minority views when we're designing processes and policies that will work for everyone, just the majority. So in the context of inclusive design, it's quite understood that it is predominantly these edge users, so those dots around the outer edges of the red circle, that contribute the most relevant, innovative, insightful, and grounded perspectives to a diverse design team. So if you want innovation or even design improvement, the best people to have at the table are people that have difficulty with the current design. So in the case of health data social license, better understanding minority views was a way for us to come to consensus on different examples of health data uses and users that everyone supported or opposed, hence being able to find what we call the center of social license, or uses of health data that were supported by everyone. So as I mentioned, the second aspect of the approach we used was facilitated dialogue. And the participants participated in 2 facilitated dialogue sessions, 2 in English and 2 in French, where they had the opportunity to share their views, listen to each other, and be open to changing their minds after listening to others. But as facilitators, we also made it clear that no participant should feel pressured to change their mind. So the first session focused on essential requirements for health data social license, and the other focused on examples of uses and users that were within or not within social license. So to help participants come to consensus, we used this 5-finger facilitation method. This was a modified approach to what's called the 5 to 5 method from the International Association of Facilitators. So the good thing about this approach is it's not just a yes or no binary type of voting. It's really about real-time expression of an individual's thoughts about a particular statement. So as an example, the facilitators would read out a statement like, it is within social license for health data to be used by university-based researchers to understand the drivers of disease and well-being. And then all the participants would show on their fingers how much they supported it. So 5 fingers is full support, fist or 0 fingers is complete opposition, or anywhere in between. I think this was quite important because the participants could still express their concerns about statements they agreed with, but they could still have concerns with it. So it wasn't an all or none approach. We would then ask the participants who were fully in agreement and those who had issues with the statement to share their views. Sometimes this resulted in wording changes, and then we would read the statement again and ask everyone to vote with their fingers again. So the statement was deemed to have consensus if there were no closed fists. So some people could have 2 or 3 fingers up, and we would still say that we had consensus. We did this for a number of examples for health data uses that participants felt were within social license, not within social license, and could be within social license with appropriate safeguards in place. And with that, I'm going to pass it over to Annette to talk a little bit about the methods that they took in Australia.
Okay, so thank you very much, Julia. The work that we've done in Australia has been a very similar set of topics to those that Julia's just talked about for you in Canada. And I'm particularly going to talk about 2 projects that we've worked on, both with PHRN and the University of Wollongong. And that's the first one, was just those 2 groups working together. And our second project about public views on the use of general practice data has a large group of agencies involved, including Macquarie University, the Digital Health Cooperative Research Centre, and Health Consumers New South Wales. So, as I said, we've used a range of different types of approaches, and I'm going to talk a little about each of them. So I'm going to start by quickly describing some focus groups that we ran at the end of 2021. And this was part of the project. It was actually the very first stage of our project on exploring community views on sharing the information that is held in people's general practice records. So we ran a set of 4 pilot focus groups, partly to help us develop a national survey, but also to get a sense of how similar or different people's views might be from other views that we'd seen reported in the literature and had found ourselves with respect to making use of people's health data. They were 4 online focus groups. We recruited our sample through a market research company, and we asked them to provide us with 1 mixed gender group, 1 female only group, 1 male only group, and 1 young persons group. Across all of those groups, we were looking for a range of genders, ages, employment status, education level, and language spoken at home. So they turned out to be quite diverse, but each group had its own particular flavour, as you might expect. Those focus groups were conducted fully online. We began each focus group with a short scenario that we then evolved throughout the focus group that went in total for about an hour and a half. That scenario started out as being a story about a patient who goes to see her GP. And then we asked people to tell us about what they thought was in her general practice health record. And then from there, she goes to the emergency service. And from there, we begin to explore other possible agencies who might be able to use her data and other people's data, both to get an understanding of what our participants knew about how data are shared, but also the views that they had about how data ought to be shared. So the second area, or the second approach that we've taken is 2 national surveys. And again, we've used a market research company in Australia to recruit for those. We asked them to stratify by age, gender, and region where people lived, whether they were rural, urban, city, country. And in each of those surveys, we had about 2,500 participants. The first survey was one that specifically focused on to what extent it was acceptable to use health administrative data in the private sector. So ought the private sector to have access to people's health administrative data? And the second survey focused on general practice, partly drawing on the findings from our focus groups and also from questions in the literature to ask a range of questions about what people knew about how their general practice data information was being used, and also what they thought ought to happen. That was in March of 2022, and again, just over 2,500 people. Both groups had a nationally representative sample. Each of those surveys provided a small amount of information to the participants. In the first one, it was about a half-page summary of uses of health information and the nature of the private health sector. In the second, it was a short video in 2 parts, which told people a little about general practice data and how it was collected, the kinds of controls and constraints on making secondary use of those data, and some information about how ethics committees were involved. Each of those surveys could be done in about 15 minutes. They were mainly multiple choice options or Likert scales, and we had a couple of items at the end where people had an opportunity to put in some free text feedback. So the third approach that we've used, which probably is closest to that which Julia has already described for you, are 2 rounds of community juries. And then the first one, held in February of 2020, just before Australia went into lockdown, we brought together 2 groups of about 20 people in Sydney and in Wollongong, which is a city just south of Sydney, and asked them to deliberate on the circumstances under which it would be permissible for governments to share health data for private industry for research and development. The second set of juries were 2 juries conducted in Sydney and Melbourne, so both capital cities, and they were in July and August of last year, again about 20 jurors in each of those juries, and we asked those jurors to address the charge under what circumstances, if any, should we share general practice data for research purposes. And I'll tell you a little more about how those approaches work. Community juries first developed in the 1970s as part of deliberative democratic approaches to collecting people's views. They begin with recruitment of jurors who are designed to be representative of the broad population. They're not there to represent particular groups, but we do recruit specifically to try to gain a broad balance across society. So our juries recruited 20 jurors, and we stratified those samples for age, gender, urban or rural, education, income, language spoken at home, and First Nations people. So we recruited those through our market research company, and then ensured on the basis of the group that they provided with us that we actually had the diversity of sample that we were looking for. We brought our jurors together for about 2.5 days in person. The second round of juries on general practice data, we proceeded with an online 1.5-hour meeting for the jurors to meet each other in the week before the physical juries actually took place. And at that meeting, they introduced themselves. We told them a little bit about how juries work, and we gave them an opportunity to practice some of the skills they would need to be using for the juries themselves. Then, beginning on a Friday afternoon in each of these 4 2-by-2 juries, we brought people together and began with some information about the topic under question. So, for example, for the juries about the use of general practice data, we told people about what the state of general practice is in Australia at the moment, what key challenges are for general practitioners. We talked about how data are collected from general practice records. They had an opportunity to have a look at a general practice record, see what it looked like. Then we took them through the kinds of uses that you can have for information that has been collected from general practice records. We talked about data linkage and how that works. We gave them examples with presenters who were working in the field of particular uses of general practice data. Then we talked with them about the legal and the policy framework in Australia around using general practice data and the way in which ethics committees and other governance bodies are involved. And we ended with a session that specifically looked at the sorts of ethical issues that might arise in using general practice data for, in this case, research purposes. That took us about a day all up. So by mid-afternoon on the Saturday afternoon, because we began a Friday evening, the jurors had an opportunity to listen to a lot of information. They had some booklets to help them follow along at the time. They'd had some small group work to develop some questions and then ask those questions of the key witnesses. And then at that point, they began deliberating. And that process went on for about a day and a half in each case through a combination of small groups and large groups. We gave our jurors some guiding questions that we thought it might be helpful for them to be thinking about for their deliberations. But we also said if there are other matters that are important to you, please include those wherever that's appropriate. And so through that process, by the time we were at about Sunday lunchtime, the jurors had developed some beginning recommendations that they described as conditions on the use, in each case, whether it was private sector access to health administrative data or use of general practice data. And the rest of the afternoon rest of the day was spent refining those recommendations and then finally voting on them. Throughout, jurors were encouraged to reach for consensus. So when we did a round of voting, we would ask jurors who were in favour, why did you think that? We would ask jurors who were against, why did you think that? And then we would follow up with, for people who are either unsure or against the recommendation, how could that recommendation be reworded for you to feel that you could support it? So there was quite a lot of toing and froing, quite a lot of rewriting of recommendations during that period. And at the end, in each case, we had broad support, provided a suite of conditions were met, and we'll go on to talk about those when we get to the results shortly.
Thank you, Annette. Well, we now have another couple of Mentimeter questions. This is quite a simple one, and I will just add before we get into the question, if anyone has specific questions around the method specifically, feel free to pop them in the chat, but we will also have time to address them at the end. So the question is, as you can see, have you or your organization engaged with community perspectives, engage with community to understand community perspectives on sharing health data for secondary purposes? So we'll just get a sense of people's kind of experience in this area. Like we've got somewhat equal, but more people than not have some experience in engaging with community about health data use, which is good to know. Okay, it seems like the responses have stopped, so I think we can move on to the next question. So this is one where you have some free text to write in. So list methods that you or your organization have used to gauge community attitudes towards the use of health data for research. Representation on research ethics boards. Yeah, I know here in the province of Newfoundland, we have patient representatives on our HREB. And I'm seeing a lot of similarities to the work that both Annette and I presented on. So surveys, focus groups, public deliberations, public advisory councils are they're a way to quite meaningfully engage and a way to kind of impact priorities. And I think there's definitely benefits, kind of pros and cons to all of these methods, right? So with focus groups and public deliberation, sometimes you're engaging with less people, but you're getting kind of deeper into perspectives. Surveys, you can often target a larger group of people, but maybe getting a little bit less granular in terms of details. Town halls, recruiting members for the project team, yeah, co-creation, that's kind of on the spectrum of public and patient engagements. Really co-creation is what we strive for, and co-design. And community advisory boards, so similar to public advisory council. So as you can see, there are definitely a wide range of ways that we can engage with community members and individuals to understand how they think about health data and the uses of health data. And I think what's important is because this idea of health data social license, it can change, right? Depending on the context, depending on what's happening in the world. We saw that with COVID-19 pandemic. I'm sure that people's views around health data use and their, ownership over their health data and all of that probably was impacted by what was going on. So we always need to kind of keep our finger on the pulse, I should say, about, coming up with ways that we can effectively and efficiently kind of gauge community perspectives. So thanks, everyone. Those are some really good ideas, and nice to see that they're in line with the ways that we've engaged so far in our work. So I'm going to pass it back to Annette to start us off in terms of what we found when we engaged with members of the public.
Okay, so I'm now going to take you through the findings from each of our different models of engagement in Canada and Australia. And Julia and I are going to tag team on this, but I'm going to talk first of all about those areas where we found that there was very strong general agreement between the work that had been done in Canada and the work that we've done in Australia. And then we'll split up and each of us will talk for ourselves about the couple of areas where we felt that there were different findings in the Canadian experience compared to the Australian experience. So as you can see there, we're going to talk about similarities with respect to views about benefits, equity and fairness, governance and oversight, privacy and security, and transparency and data literacy, and then different findings with respect to personal control or consent and the role of commercial organisations. And in each case, I'll do a quick summary of the findings for the two countries, and then have some quotations to give you a little bit of a sense of what it was like from the perspective of the people participating in these projects. So first of all, on to benefits. We found that the work that had been done in Canada and in Australia the participants there had very similar views about the need for the findings, for the outcomes of data intensive research activities to be for the public good or for public benefit. And in Canada, that it was a view that the data ought not to be wasted, and that benefits needed to be for the same people who are contributing health data for a particular purpose. So it was within social license for health data to be used to improve healthcare decisions, to understand the healthcare system, to understand drivers of disease and well-being, but it wasn't within social license for health data to be used for a purpose that was not patient, public, or societally benefiting. Again, as I said, in Australia, very similar. What we found there was that there was this very similar view that public benefit, diagnosis, treatment of diseases, gains in knowledge, particularly for health, and improvements to health outcomes were the key reasons why people felt that it would be acceptable to be making use of health data. And now some quotations to give you a feel for what people actually said. So in Australia, in our Sydney jury, talking about the use of general practice data, the jurors said that data should be used to prevent another outbreak. They were obviously talking about COVID, and identify hotspots and finding new cures or new diseases as well, basically to benefit the general population. In Canada, to support integrated team-based care, best diagnosis and treatment based on comprehensive data, to avoid harms from not sharing, to support an optimised health system, resource management, discover new treatments, target resources that are based on population needs. These quotes could have come from either country, I think, so very similar findings there. Equity and fairness was the second area where we felt that there was real similarity between the findings in the two bodies of work. In Australia, it was a strong view that vulnerable communities or priority populations needed both to be consulted about the use of their data and their particular interests needed to be protected. General practice data sets in particular, we had recommendations to suggest that if we were going to use them in research, they needed to represent the population being researched. If that were an Aboriginal or Torres Strait Islander population, then the data sets ought to be representing that group as a whole. In Canada, Indigenous data sovereignty similarly, and the right to Indigenous self-determination was acknowledged and needed to be respected. We didn't want health data being used in ways to create stigma or to stigmatise against groups. And systematically marginalised population, similarly to Australia, needed to have control over how their data are used, shared or reused. So some quotations that reflected that. In Canada, there was a perspective that individualised, rights-based approaches for connecting individuals and groups to the participation, resource and health data collected needed to be supported. And recognition that equity-seeking groups were the most vulnerable segments in society and they need extra protections. Groups that suffered discrimination the problems that they have are not going to be solved by making it more difficult to use their data. We need to ensure that their well-being can be enhanced, and that might come through data usage. Our Sydney jury in Australia, as an example of concern about priority populations, were quite worried that they, as a jury, weren't well positioned to make decisions on behalf of everyone in the Australian community. So they made a recommendation that further work of the kind that we had done with them needed to be done, particularly with specific populations, because as they said, I can't make the decision for those people because we don't live in their shoes. That's why they've recommended that we have more work in that area. Similar findings as well between the two countries in governance and oversight. Both groups of work recommended that there be accountable governance bodies that were independent, that were able to provide external third-party oversight of the use of data. Those governance bodies ought to be broadly representative and include both stakeholders who have a particular interest in collecting, using data, and also the community from which data are being collected. And transparency, again, in both countries was really important. The governance body needed to be transparent about what it was and how it worked. And there needed to be formal notices about how health data are processed, used, shared, or reused before health data can be collected. And some quotes to support those conclusions. So from Canada, accountable governance bodies that include the Public Patients for Health Data that can levy severe penalties on those that misuse data or violate laws and regulations pertaining to health data are important. People need to trust the data is being collected properly, secured and used appropriately. Not industry, university or government, but an independent body accountable to patients, professionals and those bodies. Our Sydney jury again said, well, there are lots of different stakeholders with lots of varying interests that they represent, but there doesn't seem to be a way in which we can bring all of those groups together or a framework of looking at it where everybody can actually have their say. So our next area of agreement was privacy and security. Here again, really similar findings. Ensuring that data had names and addresses removed, and dates of birth as well. That there were really strong penalties for data breaches. That there were defined roles and accountabilities for everyone involved in health data use. That there were really solid safeguards in place to protect health data. And that those data security arrangements were audited regularly and the auditing was well resourced. In Canada, there was also a strongly felt view that people had a right to be forgotten, not to be included if that was what they wanted. And that there was auditing and consequences for non-compliance. Some examples of how our participants framed or spoke about that area of privacy and security. In Canada, trust for securing safeguarding the privacy and security of our health data is low. Many of my peers have expressed it is only a matter of time that these systems are breached. Many are unaware of how their data is used or could even be misused. Some shrug it off as a cost of being a consumer. We need to be reassured that data gathering is really in the best interests of us all. Again, from our Sydney jury, the only way you can trust people is if there are big penalties for mistrust or misuse or selling the information. And this person suggested that a person misusing the information be fined and that anybody who sells the information for profit be jailed. So the final area of agreement that we saw between the two bodies of work were around transparency and data literacy. Both bodies of work found that there was a need amongst our participants recognised for transparent and plain language about who could have access to what data and for what purposes. That would mean that people would be well informed. The results and the outcomes of studies would be made publicly available, and transparency about the kinds of research that were being conducted, particularly in the private sector. Also, opportunities for people to pose and to get answers to questions about how the data were being used, shared or reused, and educational materials that increased people's data literacy, available in formats that met the needs of specific populations. So the Sydney jury recommended that information should be very accessible. They wanted to reach as many as people as possible, so everyone is kind of aware what they're getting into with this data. In Canada, participants said it's important that the purpose of data collection and storage is clear, well communicated, and known to all participants if required. The language should be a language everyone can understand with no acronyms. This way, everyone could understand and respond. And now we're going, oops, we've got a Mentimeter question.
Yep, thank you, Annette. So before we continue on talking about the findings, specifically some areas where we saw a little bit less agreement, we'll have a couple of questions. The first being, how do these results that Annette just presented compare to your understanding of community attitudes towards the use of data for research? List maybe any similarities that you see with your work and what was presented. Desire for transparency, absolutely. That's a common theme that comes up, not just in these discussions around social license, but just generally about data use and the link of transparency with trust, the importance of community benefit. Yeah, we had pretty deep or ongoing discussions about public benefit and what public benefit actually means. How do we define that? Who is in charge of defining what is and what isn't a public benefit? Plain language, again, completely related to transparency. I see the importance of security and privacy safeguards, concerns about privacy and trust. Yeah, and a lot of the mistrust comes from these concerns about privacy breaches, and we've seen that in real life, right, with different privacy breaches and people's information being shared with malintent. The importance of information being understandable by non-academics, that's extremely important, especially when we're talking about patient and public engagement, engaging directly with the communities. Again, we're seeing a lot about patient and public engagement, so that's a common theme. Yeah, desire to be involved, community engagement, and our community governance. And a lot of what we saw in our work, and I think Annette can say the same thing, is that we really do need to have members of the public, patients, however they want to be identified, really represented at the table in these discussions around health data use. Just give it another maybe 10 seconds to see if any other responses come in. Yeah, and I think that's a really good point. Findings seem intuitive. Yeah, they make sense, right? People want their data to be safeguarded, but also understand that data are important for overall health and well-being of the population. And hesitance of members to say that they represent the public. Yeah, and that's a really important one as well, especially when we're thinking about engaging with systemically marginalized or people from systemically marginalized populations. Again, you're kind of increasing the burden on them to represent a certain community or population when everyone is their own individual, whether they fit into, most people fit into many different boxes and different groups and have different perspectives. Okay, and this is a similar question. So how do these results compare to your understanding of community attitudes towards the health data, towards the use of health data for research? But we're asking you to think about any differences. So anything you saw that Annette presented that, oh, that's different than what I've experienced, say, in when we've engaged with the public. Maybe it was all very similar, but we thought it would be interesting to see if there was any sort of notable differences. Maybe this is a hard question. It seemed like there was a lot of similarities, so it's very possible that, yes, haven't heard before on an overt call for penalties and jailing in this way. Also, when we conducted these dialogue sessions and when we did this work, that was the first we'd come across, particularly around penalties and fines for people who misuse or the data breaches. But I think it might be in a bit of the literature, but it was something that was quite new to us. I don't know, Annette, if that was the first time you had heard of that as well.
It was the first time that we had heard it. And interestingly, I worked with a group in Singapore in 2021, and they found exactly the same thing. They were in their work on a very similar topic. In both both financial penalties and public blaming and shaming, and the jail terms, I think, for people who were deliberately misusing data.
Yep. Thanks, Annette. Interesting. The right to be forgotten is new to me, but makes intuitive sense. That exact same comment came up when we did the session for Australia back a couple of weeks ago. And in this context, at least in our discussion, it was really this idea that an individual can consent for their data to be used for a research project and even consent to secondary use. So saying that their data can be used for other projects, it's put in a database, for example. But the individual should always have a right and a mechanism to go in and say, no, I no longer want you to use my data. Doesn't matter how it's been used or if it's been used in the past. I want you to forget me. That's quite interesting. So I'm thinking oh, here we go. Call for an independent body accountable to patients is not wholly new to me, but I'm not sure I'm aware of many concrete examples of this. I mean, the only one that I can think of, and I think it was mentioned actually in one of the previous questions that came in, was having patient partners or patient representatives on a health research ethics board, for example. I can't think of any other examples, and I don't know, Annette, if that was something that you came across.
There are some examples of research institutes in Australia that have patient advisory boards. I think it was, in our case, it was the juries who were recommending this. And I think they were asking for something slightly different and something that was not only representing participants or community members or citizens or patients, but also including all of the other stakeholders at the table to ensure that the decision, that when data were shared, that it was most likely to lead to good outcomes.
And I know there's a number of folks here on the call who are from Health Data Research Network Canada or other organizations. If you have any thoughts or comments to add specifically to this question and this comment, feel free to put them in the chat as well. I think we can probably move on, but again, you can always put your comments in the chat. Just a reminder that those would not be anonymous. So we'll now share some findings, as Annette had mentioned, that were different between the two groups. Not necessarily opposing, but we did see some obvious differences in terms of the level of support for different uses and users of health data. So I'll start with the category of personal control and consent here in Canada. So when we talked about control and consent, the discussions really focused on two main areas. The one was people having control over and access to their own health data in a timely or in even a real-time way. And I think, you know, the majority of people here on the call are quite familiar with this, but here in Canada, at least, access to personal health information is inconsistent across provinces. So there's one report that came out that said, you know, less than 40% of people actually access their own health data, and around that same number of physicians actually report sharing patient information outside of their practice. Here where I'm based in Newfoundland and Labrador, they've relatively recently rolled out a personal health record pilot that a small portion of the population has access to. And as well, I will mention that I'm sure most of you are aware, back in early June, I think it was, Health Canada announced the Connected Care for Canadians Act, Bill C-72, I think. But really this idea of enabling Canadians to securely access their own health data, ensuring timely and secure access to personal health information. So that language came from the release that came out about the bill, and it's very similar to what we heard in our process. And then the second thing that came up a lot was the idea of consent, and in general, opt-in consent was favored by participants over opt-out consent, as there were particular concerns around privacy and security, data breaches, misuses of data, and some mistrust. On the other end of the spectrum, there were some people who we engaged with. It was the minority of people, but there were some who felt that if there were too many safeguards in place, this would really prevent the benefits from being obtained from data. So they felt that an opt-out model would make more sense. So here are some quotes around direct involvement with one's own health data and personal control. So that first one there, people deserve to have the slogan, "Nothing about us without us," applied to uses of their health data. Regarding consent, we really saw two ends of the spectrum, as I mentioned. So you see that there, no sharing without consent of the person in question, not for promotional purposes or without their consent, and that's implying opt-in consent. A couple of people also acknowledge the vulnerability of people in certain situations. So oftentimes, particularly if you're in a healthcare setting, you're receiving treatment, patients are already feeling vulnerable and being treated for care and won't say no when asked for consent. And then the last quote there on the slide, it's really the other end of the spectrum. So opt-in and voluntary only options make it difficult due to the impracticability of obtaining opt-in permissions from large groups of people. Someone else noted it's a minority of people who will not want their data used. So they must be given the opportunity to refuse without creating a system that causes barriers to research. But these I'd say were the more minority views.
So in Australia, the work that we've done leads us in a slightly different direction. And I need to preface this by saying the focus group work and the survey work tends towards saying that people prefer an opt-in model of consent, but not by a great amount. However, our jury work, which probably is the most comparable to the work that Julie has been describing for Canada, all of the juries have come up with quite different recommendations with respect to consent. In the case of the juries that we ran in 2020 about access to by the private sector to administrative health data, those juries both recommended that a waiver of consent or opt-out consent was the preferable option. For the general practice data juries, the recommendation was an opt-out consent model with choice for patients with respect to the components of their records that could be included, and with relevant community involvement in the research that might follow from the use of records, so that the community were engaged in a range of ways. I think the findings are different partly because of this particular quote. So when you run a jury, people get an opportunity not only to listen to information about about models of consent and the pros and cons of different models, they also get an opportunity to debate that together and to ask questions. So this juror, I think, has got this is a quite nice summation of why they were in favour of opt-out consent. You get the best data because we talked about the differences in response rates that you have when you want to use health data and you have an opt-in versus an opt-out or even a waiver of consent model. And this participant said, well, we can recognise that some people are going to opt out, but if we have a complete non-consent model, a waiver of consent model, people are going to be too wary to go to doctors, and that would have a negative impact on people's health. So we are giving people some choice. We're giving them the opportunity to make some decisions about whether they want to be in or not, and that is actually respecting their autonomy. But we're also trying to ensure that we have a data set that will be usable and that will give us useful data that we can draw reasonable findings from.
Thanks, Annette. We'll move on to the kind of last category in our list of 7 categories, and that is of commercial organizations. So in general, and this is from a Canadian perspective, or at least the group that we engaged with, in general, we did see kind of mistrust in the private sector compared to the public sector when considering private sector use or commercial use of health data. So the people that we engaged with highlighted the importance of data not being sold for marketing purposes or used for marketing purposes, and that commercial organizations, and that was regardless of whether they were a pharmaceutical company, insurance company, or another type of commercial organization, should have additional safeguards, conditions, and protections in place when using health data. So as a kind of a real life example, I'm sure many of you are familiar with ICES. They hold most of the administrative health data in Ontario that researchers can access, and they do offer data analytic services for private sector researchers. But there are some additional safeguards in place that aren't necessary for the majority of researchers who they work with, who are primarily from academic institutions. So, for example, private sector researchers have no access to individual level data. They work with an ICES analyst who generates whatever the reports that they need. And other examples are that ICES scientists are prohibited from receiving industry funding for projects that use ICES data. And it's important to note that the majority of ICES work is still conducted within the private sector. So that's kind of a real life example that we saw reflected in some of the perspectives that we heard. And some quotes, and again, we can see here, similar to personal control and consent, we really saw kind of 2 ends of the spectrum. So on one end, I'd say a lot of people who we engage with felt that commercial organizations care about the bottom line, which is profit and creating wealth for their shareholders. Data is forever and health data is valuable. The private sector cannot be trusted in the public's best interest because they are beholden to create wealth for shareholders. In the middle of the spectrum, it's okay for private sector to access and use health data as long as there are proper controls, as health data is not a free-for-all. And then I would say at the quite extreme end of the spectrum, we did hear that no data should be provided to commercial organizations, full stop. Another person, it's not on the slide there, but another person noted that it did matter what commercial organizations we were referring to. So, someone thought that it would be okay to share with a drug company or a medical device manufacturer, again, with proper controls. And then at the other end of the spectrum, that last quote there, we need to liberate this data for the private sector to ignite innovation for public benefit. So for the people who really supported private sector use, it was really as a way to kind of drive innovation and new technology and new types of research. But again, I would say this was in the minority, at least in the discussions that we had.
But this is an area where we found a quite different set of views. It's also important, I think, to think about the context in which we were collecting data, and our juries on this topic were explicitly designed to explore the question of whether it would be permissible for the private sector organisations to have access to administrative health data. And to support that, to support the jurors in debating and deliberating on that topic, we not only told them about how data are held in the public sector, what the constraints and controls are on that. We talked about the sorts of things that people do in the private health sector. And in both juries, we've had a moment in time where someone realised, for example, that pharmaceutical companies make drugs. They don't just sell drugs. And though that awareness of the way in which public and private sector in healthcare and health systems are intertwined probably was really important for both juries. So both juries recommended that data should be shared with private industries for research and development, but they were really clear that there needed to be strict conditions on that sharing. And those conditions were around controlling who could have access. So there were some private sector organisations they thought should not have access, and health insurers were one of them, and life insurers were another. There were controls on the type of data that could be shared, that there was an independent oversight body to monitor access, that the purpose of sharing was in the public good. So it wasn't unreasonable for private companies to make money out of using people's health data, but there had to also be a public benefit. There were really clear and strict protections, penalties and costs for the private sector, and the public were well informed. Even with all of that, though, there was still a perspective that a waiver of consent model or an opt-out consent model was more appropriate. So this is just one quote. I could have given many, many quotes, but I've chosen one that focuses on the fines area. A lot of big companies could handle a $100,000 fine because they make a lot of money. They don't care about that. But the biggest impact would be on reputation. So that's the big disincentive, and that's why they wanted a very public and transparent process for making sure that the general community were aware of how the private sector were using people's data, and if data were misused, that was made public.
Thanks, Annette. So we'll now move on to the last section of our formal presentation. So we'll summarize some reflections, key takeaways, as well as some emerging issues, and then we'll have some time for some questions or comments. So in terms of key takeaways on health data social license and community attitudes to health data use, I think we can all agree that public perspectives on data collection, use, and sharing are complex. In general, we see that there is broad support for the collection, use, and sharing of health data, but requirements and safeguards do matter. So that's this idea of conditional support. Some uses and users of health data will have more support than others in certain circumstances. So these are kind of all generalizations, but we often see support for public uses over private uses. Profit is not looked upon favorably by the public, and data use that causes discrimination, for example, or bias, and particularly for systemically marginalized populations. But in some cases, we saw, at least in our work, is that people will oppose a use or user of health data no matter what conditions are met or safeguards are in place. So, when we are looking at research that uses secondary data or links data, it is important to consider who collected the data, for what purposes, and the implications of using or sharing this data for the data owners, who are the public. And I think this is really imperative for public trust, which is how we're going to be able to get the benefits out of the large amount of data that exists out there. So Annette and I and the others from PHRN Australia and HDRN Canada, we reflected on the work that we had done in both countries and wanted to provide some of these reflections on perhaps why we saw some differences. Generally, though, we did kind of see the majority of our findings were aligned. So I'll start off, and I welcome Annette to chime in from her perspective, coming from Australia. But there are kind of a number of different ways that our work differed. And of course, the first being that we used different methods. As mentioned, we took a generative dialogue approach, and we used inclusive design, and we really highlighted minority views. Here in Canada, in Australia, as Annette had mentioned, they used a variety of different methods, so focus groups, community juries, which were probably most similar to our method here in Canada, and national surveys. Of course, different populations, the obvious one being we did this in Canada and then it was done in Australia. I would say that the groups for both the juries and the dialogues were as diverse as they could be for small groups of people. Of course, in Australia, it was a much larger and representative sample when using the national survey. I will mention here, and then I'll let Annette chime in, but an important limitation with our work is that we engaged with experienced patient and public advisors. So these individuals already knew about health data, so they were more likely to know about the benefits, but also the risks of health data use. So it's very possible that there were kind of examples of uses that our group felt were within social license that maybe others would feel were outside of social license. So we've talked a little bit about how we would replicate this work by engaging with people who kind of didn't know anything about health data from the get-go. Before I move on, Annette, is there anything you want to add in terms of the methods or the populations that we engaged with or that you engaged with?
I think probably within the body of work that we've done, there are differences between the focus groups and the surveys on the one hand, and the juries on the other. The level of support rises in general when you move to community juries, and that's partly about understanding. It's also about control. Jurors have much more control over putting constraints on their responses. It's not just a matter of what sort of model of consent should we have? Well, we want this model and it can work in this kind of way. So context is really, really important at all levels between the countries, within the methods, the specific questions that you ask. They all make a big difference to exactly what you find, which is why I think it's so amazing that things are so similar.
Yeah, I agree in that. And I think local context is particularly interesting. And I think both of our work, at least part of your work and our work, was done, our work was done in 2021, 2022, and arguably that would be the middle of the pandemic, depending on if you think that's over or not, but it was kind of just after everything sort of exploded. But I think here in Canada, we were really beginning to understand the importance of having accurate data available to understand population trends. In this context, it was, diagnoses, cases of COVID-19, vaccine uptake. But around this time as well, the development of the Pan-Canadian Health Data Strategy was happening. And that was really spurred by the realization that there was significant gaps in our health data ecosystem here in Canada. And as well, in 2022, in Quebec, there were a couple of different bills that were coming into effect around this time, but one was the Act on Health and Social Service Information. And as I said, we engaged with a group of individuals for Francophone, and they were all living in Quebec. So there was a lot of kind of talk and discussion about this particular bill, and the bill was establishing new legislative frameworks for data sharing and use. So obviously that was going to be impacting these individuals' perspectives on health data sharing and use. And I think, Annette, you alluded to this as well, different methods and also different questions. So Alison Paprisa, who led the work on our side, she had quoted that old adage in research. So what you find out really depends on how you ask the question. So of course, for us, we were kind of going at it in a more general approach, getting kind of general questions about support and opposition, versus Annette, on your side, it was really, you were getting more specific in terms of GP data and private sector data access. Do you want to add anything onto that?
The only thing that I was going to add to also give our audience a sense of how important context is, we ran our general practice data juries about 2 months apart. The first one was in Sydney and the second one was in Melbourne. And despite the fact that they had quite similar recommendations, the juries had really different flavours. The Melbourne jury, people were much more anxious. They were much more cautious about data sharing. There were some very strongly worded recommendations about not trusting government without having external oversight. And when we asked reflected back to our jurors, that we were a little surprised by the vociferousness of people's views. They said, well, we were the most locked down city in the world through COVID, and health issues have been paramount since then. So anything that touched on how people were able to access or not access health services was really important. And that was a salutary lesson for me in how much the local context can shape how people think about an issue.
Yeah, so I can imagine if you had conducted those pre-2020, right? Like you probably would have heard something very, very different. And that reminds me, we didn't go into our kind of process, our engagement process, trying to see if there was differences between the Anglophone group and the Francophone group. We just split everything up because we wanted to do everything bilingually. But we also noticed some kind of stark differences between the perspectives of the English-speaking participants and the French-speaking participants. And specifically, we found that the participants in the Francophone group, as I said, all resided in Quebec, did tend to be more cautious, more wary about private sector use. And whether that was to do with this bill that was coming into effect or anything else, we didn't really dig deep into that because we didn't approach it to look for that, but that was kind of an observation that we noticed. So context is very, very important.